Hey, good morning, everyone. Welcome. I'm Pat Franklin. I am professor of medical social sciences and orthopedics and rheumatology at Northwestern. And I'm joined today with my colleague, Lisa Hirschon, who Lisa, I will list your title and I'll be handing off halfway through this talk to Lisa, but just to warn you that she is out of the country. And we jointly put this together and we're hoping for a stable internet so she'll be able to present the second half of the slides to you this morning. Lisa is professor of medical social sciences and the director of the Ryan Family Center for Global Primary Care. That's explaining that her out of the country is work that she is engaging within, I believe, in Africa today.
Absolutely. I'm in the Great Rift Valley and actually talking about quality improvement and implementation research. So the timing is quite good.
So this morning, we just wanted to start with our session goals. And our objectives are first to discuss the goals of quality improvement in healthcare, because there is a long history that actually predated a lot of the terminology and the refinement of the implementation science that you are learning about this spring. And we will consider the similarities and differences between QI and implementation science and discuss how we may integrate the best of both as we move forward to accelerate healthcare improvement. So first of all, I'm going to refer to quality improvement as QI. Quality improvement has gone by many names. There's been total quality management and all sorts of phases, but quality improvement is really focused on the incremental implementation and adoption of both the what, the thing, and how. But I would say that it's been specific to certain practice settings. So the science of generalizability is what you're going to hear a lot about, has not been primary in the work of QI. QI teams are usually drawn from the real world staff working in a particular setting with a goal to implement a best practice and that will both improve outcomes. And there's a big process focus on reducing variation in care in quality improvement. So for example, if you were working in a clinic and you saw that your plan was to consistently provide patients with education at the time of discharge from the hospital that would explain how to best manage their care until the next visit. And it didn't happen consistently. Some days it did, some days it didn't. That's what I mean by variation. Excuse me, so that the process is in place, but the staff, either the resources, the staffing, the logistics, the infrastructure doesn't support consistency. So QI is both focused on, as they would say, moving the average or moving the mean or the general practice, as well as reducing variation in that practice so that there would be reproducible, high quality care. And then the quality improvement process is often conducted using a structured rapid cycle adaptation. So for example, in the example I used, if I found that on days when we're understaffed in the clinic or when the IT was slow, people didn't print out the education material, we would find out what's the cause and say, can we address that cause? So there's a very focused, solution-oriented, rapid cycle process with the goal of improving consistency of care. Now, this is not unique to healthcare. In fact, these improvement science strategies were developed for manufacturing processes about 100 years ago. A man named Short was the initiator who developed these processes in the 1920s, but they became really more mainstream in the 50s when Deming and Duran adopted these industrial process improvement science strategies, particularly in Asian cultures. So for example, the US was very familiar when these improving practices were introduced to the Toyota, and you may or may not be aware of this, but they were one of the leaders in really driving error rates to zero. Is what they were saying is that if we produced an engine We wanted it to be perfect every time, reducing the variation in any performance that you may experience when you owned this car, and that reducing the variation with a goal of zero error rates or deviation from process was why it was a model that appealed to healthcare. Because as you know, certainly when we're thinking about adverse events or complications, the goal is to drive it to zero. So Don Berwick, excuse me, I'm going to drink of water. Don Berwick, who was a physician and a quality leader in the late 70s, early 80s, initially began a program called the Institute for Healthcare Improvement that still exists. It's situated in Boston, and it really is a national and international leader in the thought processes and the training of professionals who lead quality improvement initiatives in healthcare settings. The Joint Commission for Accreditation of Hospitals and Healthcare require quality improvement activities in all healthcare settings. So, you will find that the tools of quality improvement, including control charts, and I'm going to show you what I mean by that, are pretty now uniformly adopted in most healthcare settings. So I have two images on this slide, and on the left, I wanted you to see that today, many healthcare systems use something they call lean, L-E-A-N, or Six Sigma, and it's really the nomenclature around process management in healthcare, and it uses the cycle called DMAIC. So DMAIC stands for define, measure, analyze, improve, and control. So for example, in my example, if we defined the issue as inconsistency in patient educational materials being provided to patients at the hospital, we might measure and say, well, how often are they receiving it? Is it 50% of the time? Is it 80%? Our goal is 100%. And why does it vary? And then we would say, if it varies, why? Is it the resources? Is it the staffing? Is it the patient receptiveness? Is there something else that varied in the context, leadership, or culture that may impede consistency of that process? And once we identify, that's often called a root cause analysis. Once you identify those causes, you then may turn to an improvement activity to address those limitations. And then control just means to monitor and watch that things remain consistent. So on the right, this is an example of what's often called a control chart that you would use to monitor that process. So I'm in my clinic saying, the failure rate here, we'll just assume, since it says on the y-axis, that the defects per 1,000 is around 5.6%, that green central line. And you might say, oh, gee, we want the fewer than 5% of patients to have that defect. In our case, might be not receiving their patient education material. So we'd say, it varied by month to month. We watched it for 6 months from June 2018, or actually that's longer, through September 2019. So we watched it for a year. And then there was this one point that was really high. Why did it double? So that 10% of the time we did not achieve our goal. And then you do that kind of root cause analysis that I described, where you drill down and say what was going on and resolve it and begin to monitor. And you might see over time, you see that red line with the declining trend. There's less variation. And in fact, there may even be a new average that's less than 5%. So that's progress about exactly what I meant about moving the average of the performance metric, as well as reducing the variation in care. So it's a constant, consistent practice that all patients could experience. That's the goal. And whether we're measuring readmission rates or adverse event rates or infection rates or other undesirable processes, these tools and this philosophy of rapid cycles of going through those steps and thinking about how do we drill down and reduce the variation is the goal of most quality improvement activities. So I thought with the next 2 slides, what we would do is I would take these concepts and map them back to the implementation science frames that you've been using. So this is a slide from earlier this semester where you talked about, compared to efficacy and effectiveness research, implementation science is focused on a thing that we're implementing, on that process of implementation, not really evaluating whether it's right or wrong. So I didn't say that education is right in the last slide. I said it was desirable and we had accepted that education was going to happen and we want it to happen uniformly. So in that case, we're focused on the process, not really. So the thing is defined, it will be implemented. We decide, is the unit of our implementation a group of patients or a group of clinicians, or is it a particular clinic? And the example I used was very local. It was in a clinic within a health system that wanted to understand why there was variation and to remove that variation so that patients all received the same care. So then we'd go in and we want to evaluate, did providers or the clinics do the thing correctly, right? Reducing variation. And we use a real world clinic, all real world clinic and staff, which is not really supported by researchers, right? It's really the real world. In the context box, though, I want to point this out that here, in implementation science, because we're seeking generalizable solutions, we really do want to understand what is the context, what were the resources, the motivations, the cultures that while we were leading through this change. And in the bottom box, the validity part too, we want to pay attention to the validity of our strategies so we can make a comment about these strategies worked or they didn't work, or we may allow for some minor adaptation. So what I did was take these same attributes along the left, and so it's the thing, the population, the outcomes, the intervention, context, support, and validity. And now I'm just going to take that last column, implementation science, and compare it to QI. And here's where I think, with after our conversations, because this is not, there's a early literature comparing QI and implementation science, but it's not as evolved yet as possible, but Lisa and I, went over these slides and agreed that this is how we would summarize the differences. Is that we see, you may both an implementation science research study and a quality improvement initiative may address the same quote thing, that intervention, and we do have to pay attention to the population addressed. In quality, because you're usually the staff within a single health system, you're really focused locally. You're looking at your local clinics, your local processes, and you make assumptions in some ways about the context. You want to assess, did we do the thing correctly? We want to understand that it was embedded in a real world, clinicians and clinic, but it's often a single site or a local site. And I would say the first major difference would be this attention to generalizability. So the thought that the context, what varied in the outer and inner systems, what varied in culture, in resources, in patient mix, heterogeneity of clinicians, there's obviously, as you know, from the frameworks and implementation science, this great deal of attention to measuring and understanding that variability in context. Where if my job is to improve the clinic performance in clinic A within Northwestern medicine, I may just assume this is how we staff. This is how we have, these are the resources. And I'm going to come up with a process that works in that setting, right, to reduce the variation. So I adapt to suit the setting. And it's not necessarily documented what those assumptions, contextual or resources others are, because it may be the norm in my local environment that may or may not be easily applied to other settings. So if I were to go to the Institute for Healthcare Improvement and say, oh, we reduced the process, the variation in processes for education after the clinic visit, the why of, it was associated with this change in practice is important, and I would know that. But I may not be able to articulate or have bothered to label the differences or the assumptions in my setting as opposed to others. So it may not be generalizable as presented to your setting in New York City or San Francisco or in other cases. Where in our implementation science literature, certainly the effort is to make sure there's been a very well-defined contextual analysis and understanding measures and adaptations that were introduced during the study. So this whole idea of generalizability, so it can be reproducible in other settings, I think is a critical feature that implementation scientists bring to the strategy, where there may be some quick, rapid cycle, DMAIC or plan, do, study, act cycles of improvement in a QI. The solutions are local, they're valuable, they're maybe measurable, but if I wanted to then say what was generalizable beyond my local setting, I would have to pay attention to, first of all, contextual factors that may have influenced the implementation strategies or the adoption of those implementation strategies. I certainly would pay attention to what may have been different in my patient, clinical, or community factors, particularly when I'm focused on equity in the implementation strategy. That may be an assumption locally. I know what the mix of patients are, but we're being, often paying attention to that and measuring that in order to support generalizability in implementation science. We will be looking at what implementation strategies worked best and in which settings. So that implies that much of implementation science uses multiple settings or a multi-site for that reason, to say, is this really a strength of the implementation strategy because it was reproducible across variation in sites, or it was modified or adapted in different ways in different settings? And then finally, what were the outcomes, the implementation and why of my process? So this slide, our goal was to really just summarize what we think the differences that we and others believe between QI and IS is to look that in the QI, there's often a local change priority focused on reducing variation and improving practice and consistency. There often are change packages, meaning I might have changed something and then in that rapid cycle didn't reduce the variation as much as I wanted, so I changed a second thing. So I might have changed staffing, I might have changed the IT. There's less of a focus on pulling apart the refined components of the implementation strategy and on the context. And finally, the knowledge is usually very local. Saying it works here, I'm monitoring it, I'm managing the control, the control chart and monitoring the sustainability of those changes over time. And if it does, quote, in the language of quality improvement, become out of control or have a special cause variation, I would repeat the cycle and say, what's different? What changed? Oh, the staffing changed, there was turnover, we have to re-educate, we have to re-implement new procedures. So that's a very, so I think that the spirit, I hope you hear that the spirit of improvement and a focus on process and strategies are consistent with implementation science, and there may be lessons from QI that we could generalize in its focus on rapid improvement to implementation science, but it doesn't always address the rigorous process of context and generalizability. So I'm going to advance the slides now, and Lisa's going to lead us through the next set of the slides.
Great, thanks so much, Pat, and hopefully my video will hold. If not, I'll cut it. So before we sort of dive into some of the next steps, one of the questions that I get asked is, well, what about this thing called improvement science? And this is something that sits perhaps a little bit in between and probably has a lot more to do with implementation science and implementation research. And it's defined as how to reduce the gap between what is actual and what is possible. That should sound very familiar to everybody. And it focuses on systematically and rigorously exploring what works to improve quality in healthcare and the best ways to measure and disseminate this to ensure positive change. And that's from the Health Foundation. And you could probably draw a lot of links between that and implementation science. And there's some people who believe that improvement science is really something that's within implementation science, but focusing more on things that are directly related to quality improvement and those methods that we tend to use, such as quality improvement collaboratives or even things like PDSA cycles. So again, it's bringing in methodology, especially learning and documentation, a framework, and this is an opportunity, I think, where implementation science can help people doing quality improvement by strengthening how we're doing this. And a lot of people think that with improvement science is, can we figure out some middle ground, incorporating the nimbleness of learning from quality improvement and how that can actually strengthen implementation science, while implementation science can help actually extract out some of the generalizable knowledge that we might be having from quality improvement. And we'll sort of talk a little bit about one case study. I'm currently in Kenya for a cross-country meeting for NEST, which is a project in which Northwestern's involved to improve sick and small newborn care in level 2 nurseries, of which one of the improvement strategies, in addition to equipment and other thing and policy, is actually quality improvement. But yet, how do we actually apply implementation science to know whether or not our QI is actually working, and how can we accelerate so that when we go to 60 sites in Ethiopia, it's a way of not doing this site by site and problem by problem. Next slide. So the question again is this idea about, can we take this sort of local knowledge and the richness of what's happening at these clinics, for example, the one that Pat talked about, and so how can we actually use this for improvement science? And again, creating this practical learning that can make a real and timely difference. So the idea is, again, the time frame a lot of times for improvement is actually quite quick. People don't want to wait 2 years to improve what's happening in a clinic, but can we actually figure out how what happens in one clinic inform what happens in the next 5 or 10? The idea is, again, creating both local wisdom and generalizable or transferable knowledge, that you do need to use well-established research methods, but you're trying to focus both on that local improvement as well as producing the knowledge. Whereas sometimes implementation science will ultimately cause change, but isn't as driven by the local demand. It can apply or contribute to actionable theories of how change happened. So what, for example, were the strategies that worked? What were the contextual factors that influence whether or not your quality improvement worked in one clinic or with one population or another? But it really requires partnership and a commitment to ethics around improvement. And often what you'll see with this is that you don't do randomized controlled trials because there's a desperate need that's been addressed. But the question is then, how do we actually figure out how to do the improvement, but do learning at the same time? Next slide. So this is sort of an option that was, and this comes from actually one of the papers that we had given you as an optional one, about integrating this sort of rapid cycle PDSA or DMAC with an implementation science model. And so what to parts of the implementation research logic model, you have pre-intervention, and there again, you have those factors. You have community, you have health system. This had to do with mass drug administration, so your actors would be actually your drug distributors. You had the intervention components, which had to do with community education and mass drug. And then you also had the individual factors, what we would call the actors within the consolidated framework for implementation research. You have an intervention. Now, instead of that being the specific strategies, the strategy itself is the DMAC or the Plan, Do, Study, Act to do these interventions. And then you want to evaluate, did this actually work? And then can you actually use this to drive further change? So an evaluation of your QI strategies, which is not something that you normally would do for a local quality improvement project. And so again, the question is, can implementation science design include this PDSA cycle so that you're actually continuously improving? It's probably the ultimate in adaptive study design. And then this idea of rollout implementation optimization. So again, this idea about how are you both making changes, but also documenting and learning. Next slide. So it goes back to some of these foundational assumptions, and sorry, I think our transferring back and forth of slides didn't do anything good for our formatting. But again, if you go back to what Pat says, again, it's the same goals, getting the evidence-based intervention into practice. Quality improvement really focuses on fidelity, but it is an implementation outcome. But again, success is defined differently, and the methodologies can differ. And again, it gets to this idea of local knowledge versus generalizable knowledge. Next slide. And so the traditional role of QI is the local, but if we integrate implementation research into quality improvement, perhaps we can actually do both. Next slide. So why does traditional quality improvement need to evolve? I mean, Pat's already told you that we can figure out how to get education to people before they get discharged in one site. So the first is that there's often multiple causes at multiple levels, and some of them are local, but particularly in the settings in which I work in low and middle income countries, there are indeed some systems and some policies. So for example, there's a gap in knowledge and competency to deliver care. We do training, people get more competent, but the policy is such that the nurses actually rotate. So we've trained these nurses to do neonatal care, and all of a sudden they're on the maternity ward, or maybe they're on the cancer ward. So we need to do policy, or maybe there's actually not enough human resources and we need a system change. Training and experience in quality improvement is limited, but even more so for implementation science. And so figuring out how we can actually expand this in both at the same time. Again, we have staff shortages and turnovers, so we have these short-term projects. So we have things which succeed, and you go back a year later, nobody has any knowledge of that, because as opposed to implementation science, there isn't as much focus on understanding the strategies for sustainability. The focus on local change often misses these opportunities for broader learning, and solving one problem at a time is not going to give us the speed, the scale, or the sustainability that's needed to actually help us reduce the preventable and amenable morbidity and mortality. Next slide. And so for those of you who, oh no, go back. Sorry. There. So those of you may or may not know this, this is actually an arcade game. It's called Whack-A-Mole. And there's actually a book that's written about this. And the idea is that if you're just focusing on one problem, you might successfully whack the mole. But in the meantime, another mole pops up. And if you whack that mole, a third mole is going to pop up, as opposed to really thinking about things from a much more holistic approach, such as what we might do with an implementation research logic model. Next slide. So the other reason we need to do this in low and middle income countries is that there's about 5 million deaths that are due to poor quality. So this was a project that I was involved in 2018. More people were dying because of poor quality than because of non-utilization. So we could keep on building all the clinics we want, but we're not going to actually address those 5 million deaths, which is actually $6 trillion in economic welfare losses per year. And this has been shown sort of again and again. And so clearly whatever we've been doing with quality improvement helps locally, but is not going to actually help us achieve the type of change we need. Next slide. This is just a thing, it's across all different conditions. So this is actually, if you look at the contextual factors, doesn't matter what kind of condition you have. The deaths that are due to poor quality are the red ones. So you're seeing this across all of them. Next slide. And particularly in terms of equity, it's poor quality for the poor. So the dark blue dots are the poorest, and what you can see is generally they are the left. So we have these equity gaps. So even if people are doing relatively well, if they're relatively well off, we call the least poor, the poorest care is generally for the people who are the poorest. Next slide. So this is an example that we sort of shared, which was sort of how people applied the REAIM framework to what was a quality improvement intervention. So lymphatic filariasis is a preventable condition. It's got huge morbidity. And there's a known evidence-based intervention, just mass drug, and you can actually eliminate this, but very poor uptake. And so they studied the quality improvement using some implementation science methods. So they did some relatively rigorous formative work to identify the contextual factors at the individual, community, and system level. They did strategies designed to address, this should sound very familiar to all of you who've been attending this course. And then they applied REAIM to measure the implementation of the strategies and the uptakes of the evidence-based intervention. And you can see this is the model that they use. Now, similar to some other quality improvement, and I don't mean to sort of badmouth it, the results were perhaps more modest than presented. So if you just read the abstract, it seems like it was a huge success, but they did have good expansion. And they did have some outcomes that went beyond simply measuring coverage. Now, one fault of this is they actually didn't describe the PDSA. And so I think this was a lost opportunity for trying to truly integrate quality improvement and studying quality improvement using implementation science. Next slide. This is another one. This is moving beyond behavior change. And so the idea, this is actually quite a ambitious approach. So we know that a lot of maternal deaths are actually not necessarily related to poor quality of care, although certainly a number of them are, but they're related to system failure in a lot of low-income countries. So that not the right care at the right time of delivery. So particularly women who need cesarean sections, who have bleeding. Traditional quality improvement focused on improving transport and quality of care at the primary center. So where the woman first showed up, and then if she got into trouble, improving transport. But this often failed. Often if it was at night or there was flooding, there was no ambulance available, maybe the midwife wasn't there. And so the model of care may be wrong. And so to do this, it really needed both implementation science and quality improvement. And so the concept, and this is being led by Margaret Kruk and the Quest group, is that health system redesign is a structural reform and will require strategies at multiple levels, from national and policy to the community and the facility. And it really is an equity-driven intervention, because the global double, to quote her, the global double standard in childbirth care, in which virtually all women in wealthy countries deliver in facilities, one could argue if that's actually working totally, but anyway, with advanced obstetric and newborn care, while women in low-income countries are asked to deliver in basic primary care facilities, can no longer be tolerated. Next slide. So before we go to our discussion themes, I don't know if there is any quick announcements. I certainly don't have any, but I'm going to give this over to the reading course people.
I don't think there are any announcements on our end. So.
Okay. So before, just as you're moving into your breakouts, we had just thought we would close with a few discussion questions that you might consider and see where the conversation leads in your groups. But certainly, so we suggested that QI involves, we hope you saw, within health system and very local knowledge generation, can be rapid cycle and reduce practice variation and or improve outcomes. So how could a multi-site implementation science focus on and integrate some of that rapid cycle, which Lisa just gave you some nice examples of the efforts, particularly even with multi-level system changes as well as local changes that may be involved? What strategies can local QI initiatives adopt to affect broader goals of implementation science so that they would serve they could honestly be preliminary data in many ways for broader implementation science studies? And what opportunities do you see there? And how can the approaches of QI inform how we do implementation science? You know, what are those integrated best practices? And you know, I would
for having both.
Yeah, no, I was just going to thank you too. That was exactly, I was going to thank you for listening to this, because Lisa and I both trained in quality improvement, health system change leadership, and in clinical epidemiology and health services research. So it leads into implementation science, but it wasn't in the initially in the vocabulary of implementation science. So this melding and the merging of the sciences is really an important, we think, next step. So we'll appreciate the opportunity to present to you. And I did want to say one thing is that PCORI, the Patient-Centered Outcomes Research Institute, has just dedicated millions of dollars to an initiative they're calling the Health System Implementation Initiative. So that successful implementation and other research, CER and PCOR, they will have a call for implementation to just study the implementation of those strategies. And they actually mandated that it be in partnership with QI, so that people will be in the health systems across the country. There are 42 health systems, and Northwestern Medicine is one of them. But there will be a wraparound of some of the evaluation, and particularly the contextual factors and the sustainability, et cetera. So, so this is a broader theory, topic than just us discussing this today. There's obviously, funding initiatives that are beginning to think about the blending of the two, and scientific reasons.
Well, thank you so much, Pat and Lisa, for your time and for your expertise. You've given us a lot to talk about in our discussion. So I'm sure everyone on the call is giving silent claps. But we look forward to chatting in our small groups now.